I'm with Dr. Akiko.
Yes.
Thank you very much. Everybody knows you, so there's no need for introduction. And you are the amazing people. You are doing a lot of the imaging all over the world. I have seen each and every conferences. You are giving a talk, moderator like that, and you have a lot of contribution in the imaging field. And it is really honor for our you have joined the BIT. I think so. It is the first time in Bangladesh and first time in the BIT. So, can you tell something that about the BIT and the few words about Bangladesh? How the shape it is?
Sure. This is really the first time when I come to the Bangladesh. And I think when I arrive in the airport and then go out, I think I see the inner energy of the country. Looks like this is developing like the country which having a lot of energy and a lot of people. And that's what what I found. And actually, it's quite similar in terms of the conference too. Because last night I see so many like young interventional cardiologists is singing the song and like together, and that seems to be the culture of this country as well as the BID.
Okay, thank you very much. And other thing is that the now you are dealing with imaging. Do you think that the IVUS should be used each and every patient?
Um, no, I think like of course, my hope is everybody, but I think like somebody having the issue of the cost and then somebody having the different aspects. So I think like you should start to be familiar and comfortable. That's number one. To do so, you need to start with the case first. But at the end, you have very familiar how to do it. And then once you see the angio, you already have the idea how it looks like IVUS inside. So once you have that level, I think you can start thinking what is the priority of the imaging. And to me, I do understand what is the ESC guideline tells us. I think the complex lesion and the leftoma is most important, and the calcified lesion makes sense, and the instant stenosis makes sense. Long lesion and CTO and bifurcation makes sense. But if you see the super simple lesion, like type A lesion, I think I'm okay. Just go ahead to the angio only. But as long as you see any type of the concern issue during the case, I may have the complication, I may have some which I don't think so. And in such, and imaging can tell you what is the inside looks like.
If you go for the ESC and SSC guideline, ESC says that is class 1 indication, especially leg main, and SEC seems to be published in the SEC class 1 indication. So, do you think that if there is a simple leg main lesion, no LCX ostium, nothing there, and LCX is non-dominant, and do you think that anybody should put a stenting without imaging for leg main? Very simple, not complex.
Yeah, I think no, I think the leftover is to me the be most important because that supplies 70% of my code, no matter how looks like simple. And if you cannot make any mistake, that's really correlated with the mortality directly. And even though you think the simple, when I see the picture, even after you put the stent nicely expanded, ostium can be deformed because I see like 9% having such issue, or like you don't know your stent is perfectly inside of the left arm but can be protruding a little bit in the bifurcation. There is a multiple issue. It's a very short segment. It's a big artery, but I think because of the how important of the left arm, I do think the left arm must be 100%. That's my opinion.
Okay, thank you. So, the take-home message from your interview that in leg main, all the patient has to be implantation of stent by image guided. If there is no image, don't go for the leg main PCI. That's right.
Yeah.
Straightforward. The simple statement.
Yeah.
Okay, thank you.
Thank you so
Thank you,
much.
Akika. Thank you for coming here, and thank you, my friend.
Thank you.
Hope you will come in BIT next time.
That's to be confirmed.
We hope so.
Okay.
Okay, okay.